Very good evening to all of you. Welcome you all for the second Meet the Expert session. And today we have two interesting talks on update on cerebral palsy. I'd like to request President Professor Shefali ma'am to introduce the speakers for today, the experts and the moderator for today's session. Over to you, ma'am.
Yeah. Thank you. Welcome you all. We will be having an update on cerebral palsy, and I think you know both the speakers very well, and I don't have to waste their time to introduce them because they get more time to speak. Today we'll be having two talks. Asmita, can you please show the slides in any case? Uh, uh, First one is by Understanding Dyskinetic Cerebral Palsy by Dr. Tajul, who is from Malaysia and who has been there with us for all the sessions on movement disorders and CP. Thank you so much. And Dr. Biju Hamid, who is in Gosh as well as UAE. And we are very grateful to both of you for having so much support for all these, webinar series you've had for the COE and then with the AOCN. And now I would like to introduce the experts. The experts for today, we have, can I have the next slide, Smita, please? The experts for today, we have Dr. Asmita, can I have the next slide, please? We have Professor Kusrat Bora Karman, who is Professor of Pediatric Neurology from Ekşehir Osmanlı University, Faculty of Medicine, Department of Pediatric Neurology, Turkey. Sorry for the pronunciation issues. I hope
it's not problem.
It's no problem.
It's okay.
He has
It's okay.
It's okay. Okay. Special interest in cerebral palsy. And our dear friend, Professor Hassan, has introduced us to him. And the other expert we have is Dr. Farida Jan, who's Associate Professor, Head of Department, Pediatric Neurosciences and Rehab from Sindh Institute of Child Health and Neonatology, visiting consultant, Liaquat National Hospital and South City Hospital, Pakistan. I think that was okay, right? Pronunciation. And her interests are also in drug-resistant epilepsy and pediatric behavior issues. And she is a pioneer member of Child Neurology Society from Pakistan. And Dr. Mary, I doesn't need introduction to this group. She is a professor and head of pediatric neurology in Trivandrum. And she has been there with us for a long time. And she is in there with the Government Medical College Trivandrum, a very well-renowned pediatric neurologist. And our moderator for today is Dr. Ekta Agarwal, who is a budding pediatric neurologist. And she's heading in the Sambhav Pediatric Neurology Development Center, Jamshedpur, Jharkhand, a pioneer in the outreach activities. Thank you, Ekta, for joining. All over to you. So first we'll have Dr. Taj, followed by Dr. Biju. We may have questions in between and after. After each talk, we may have expert comments. Thank you.
Good evening, everybody. So without wasting more time, we are already 5 minutes into the session. I invite Dr. Taj for his topic on understanding dyskinetic cerebral palsy. Dr. Taj. I'm sorry, I'm more used to calling you Dr. Taj. I know your full name is Tajul, but we fondly remembered you as Dr. Taj ever since I met you in Pune.
No problem. Thank you very much.
That's what I also introduce him. We all introduce you as Dr. Taj only. We never call you Tajul, right?
No problem. That's fine. I'm more than happy to be introduced in that way. No worries. Good evening and Assalamu alaikum warahmatullahi wabarakatuh. Good night to some of us. I thank Professor.
Thanks for attending and so late in the night for us. Really, thank you so much.
No worries. I thank Professor Shefali and also Dr. Mahesh, for the great invite. As usual, I'm going to talk about a topic that is of very great interest to me. But just a preemptive warning, my talk will be slightly fragmented today, as such would be a choreiform movement, which is a fragmented movement disorder. Shall we start the slide? So the topic of my talk today is understanding dyskinetic cerebral palsy, which is a meaningful journey to most of us who are very much involved in managing children with cerebral palsy and movement disorders. So none disclosures for me. So I would like to dedicate my talk today to all children with cerebral palsy who are my great teachers, always been my great teachers, and their parents and caretakers who are very resilient, patient, and proactive people. And I'd like to also come up with the slogan, cerebral palsy is not the end of the story of the road, but it's the beginning of a meaningful journey, especially for me and for the children that I care for. So this is just a brief slide on the content. Now, the definition of cerebral palsy, I'll just start with that. I don't think it's justifiable for me to start with a talk on cerebral palsy without the definition by Rosenbaum, 2007. They're defined as a group of disorders of development of posture and movement, causing limitation in activities attributed to non-progressive disturbances in the developing fetal and infant brain. I think most of us are very much familiar with this, what you call definition, which has set a benchmark of how we are going to diagnose a child with cerebral palsy and then designate them. Cerebral palsy is basically what you call a term to describe a state. It's not a disease at all. So it's the most common cause of motor disability in childhood, affecting at least 3 or 4 of every 1,000 children. But one of the most important point for us to remember when we are speaking or describing cerebral palsy, it has to be caused by a non-progressive impairment, non-progressive insult, non-progressive pathology, versus the symptoms which may be evolving throughout the years as you care for the children. The etiology for cerebral palsy spans from any insult that can take place, even preconception, maternal illness, to antenatal period, perinatal period, and postnatal insults. So majority of the insults take place, 80% are caused by prenatal factors, 10% would be the rest. Now, hypoxic ischemic encephalopathy has been what you call the most favorite, blame site that we get most of the times when we encounter a child with cerebral palsy. However, contrary to common emphasis, HIE might not be the most commonest cause for cerebral palsy, especially dyskinetic cerebral palsy. So cerebral palsy may be caused by a wide clinical spectrum and various etiologies. It's not one, it's not two, but it leads to a common pathway, common insult, or common damage leading to a certain syndrome. Dyskinetic cerebral palsy, even more, caused by heterogeneous etiological factors, including metabolic as well as genetic factors. Now, to begin with, it's always history and physical examination, the cardinal step in any neurology or approach of neurological cases. It is the essential component for diagnosis of cerebral palsy. First, in the history, we have to look for evidence and risk factors for prenatal, postnatal, as well as any antenatal causes that may predispose a child to develop cerebral palsy. Of course, in the history, the few aspects or points that we can ask would be delay in attaining milestones, any asymmetrical motor functions, hand preferences, or any impaired posture. Apart from the above, a serial neurodevelopmental assessment is of paramount importance. This is something that I would like to stress because most of us who have been caring for children with cerebral palsy may agree with the fact that we may not be able to diagnose children with cerebral palsy, or we may not be able to broach the topic that your child might be having clinical signs and symptoms of cerebral palsy at the first or second clinical visit. It may take months or weeks for us to observe the child, assess the child, and keep stressing the fact that the child is not developing normally to the parents, and slowly come to a diagnosis of cerebral palsy with the great confidence. Now, to recognize cerebral palsy, one of the cardinal signs that we need to look for is a motor dysfunction. If there are no motor dysfunction, out forth, we know this is not a child with cerebral palsy. So, any child to be diagnosed as cerebral palsy or to be designated as cerebral palsy, motor dysfunction in a form of either tone, movement, posture, or any form of motor neurological deficit should be present before we make a diagnosis of cerebral palsy. Now, it's possible that a motor dysfunction might not be evident in the early stage. It may evolve as the child develops, as the brain develops. So most of the times, the motor dysfunction or the motor impairment may be evident by the age of 12 to 18 months. But to a keen eye, to an experienced eye, experienced hand, and experienced mind, you may be able to recognize certain children with cerebral palsy or certain children with the risk of cerebral palsy at the age of as young as 4 to 5 months old. So the basics, again, history taking, clinical examination, neuromotor assessment, MRI imaging may be helpful, but it may be helpful in trying to diagnose the etiology, but not to make a diagnosis of cerebral palsy per se. So in the event that there are certain signs and symptoms that are iffy and we may not be that confident to make a diagnosis of cerebral palsy, but at the same time, you suspect this child is going to develop to become cerebral palsy, I'd like to use the designation of high risk of CP, put it up there so that anyone who sees the child, assesses the child, has the thing in their mind, okay, look, this child may develop cerebral palsy or has a risk factor for cerebral palsy. So again, the customary slide for describing types or subtypes of cerebral palsy, the most commonest spastic cerebral palsy, a child with spasticity, upper motor neuron signs. Dyskinetic cerebral palsy, children with chorioathetotic or dystonic cerebral palsy. The less common ataxic cerebral palsy, children with cerebellar damage and developing cerebral palsy or cerebellar involvement. And of course, the very much uncommon hypotonic cerebral palsy. When a child comes in with presents with dyskinetic cerebral palsy or hypotonic cerebral palsy, I may be inclined to look for more information to make sure that this child is not suffering from something else, which could be a mimicker or impersonators. And of course, one of the upcoming subtype classification is a mixed cerebral palsy. This is a connotation that has gained some interest in the recent decade, as we have learned to realize that majority of the patients that present with cerebral palsy may not be suffering from only spasticity. They may have some other movement disorders which are superimposed, for example, choreiform movements, chorioathetotic movements, or dystonia per se. This is a slide that I pulled up in one of the websites, Cerebral Palsy Alliance, where they've given some percentages for the incidence of cerebral palsies. Of course, as I mentioned before, spastic cerebral palsy accounts for the majority of the cases, and then followed by mixed and athetoid or dyskinetic cerebral palsy. And of course, the rarer ones are hypotonic and ataxic cerebral palsy. If you're keen to look through the papers where they've mentioned or they have gone, for observational studies on incidence of cerebral palsy, the numbers change, the percentages change. And I think in my clinical experience, when I started my practice a long time ago, spastic cerebral palsy was probably the only aspect that was going in my mind. But as I grew and as I learned from these patients, you'll be able to realize that majority of them have some form of dystonia or chorioathetosis, although they may not be the predominant feature. Now, what are the aspects that leads to these differences in reports or percentages or incidence of subtypes of cerebral palsy? One would be, I must say that assessing dystonia or movement disorders is particularly difficult when it coexists with spasticity. And we must bear in mind that dystonia or the choreiform movements may not be evident at all times, because to a certain extent, they are influenced by the emotional state or the patient's response or patient's volitional movements, which may exacerbate or which may to a certain extent sometimes ameliorate certain movement. Hence, it may not be evident at all times. Besides that, this is something that I found difficult in the very early stages, assessing movement disorders and trying to tease out one movement out of a child with cerebral palsy is not an easy task. And followed by, it's not easy to implement a certain scale to look at the disability or to look at the severity of a certain movement disorder in the aspect of a child with cerebral palsy. It is not as easy as we would, implement a dystonia rating scale in a child with a primary dystonia, a DYT1 dystonia, versus in a child who has got cerebral palsy, who may also have spasticity with mild rigidity plus minus, contractures. So these are probably the few aspects that I can come up with, which may explain the differences in prevalence of different types of cerebral palsies around the world, across the board. Now, When we speak about cerebral palsy, we know it's a issue with tone, posture, and movement. So majority of them present with hypertonia. Hypertonia is basically defined as an abnormally increased resistance to an externally imposed movement. So it is commonly found in children with cerebral palsy with spasticity, rigidity, and dystonia. Rigidity is slightly rarer, but dystonia and spasticity. However, in dystonia, the hypertonia may not be persistent or may not be at all times, as we know that in dystonia, the tone may be variable at times. When it comes to dyskinetic CP or DCP, most of the times what we come across would be dystonia, chorea, and in rarer aspects, rigidity. In majority of the cases, in majority of the reports, they have reported about 6 to 10%, and some reports say 15% or 20%. Whereas, as I just mentioned before, mixed cerebral palsy, which is kind of a potpourri of movement disorders in a child with cerebral palsy, in some children, you may have slightly predominant spasticity superimposed with rigidity or dystonia, whereas in others, you may have spasticity with chorea. And you may come across cases where in the first few months of life, it's a spasticity superimposed with some choreiform movement or dyskinetic movement, which may slowly evolve to show a child who has got dystonic CP rather than a dyskinetic CP per se. And hypotonic CP is probably the rarer ones. And if you see a child, if you come across a child with hypotonic CP, think of mimickers or impersonators. This is a slide to probably highlight the fundamental differences in different hypertonic states. So when you speak about spasticity, the cardinal feature is it's a hypertonia which is velocity dependent, whereas dystonia and rigidity are never velocity dependent. And differentiating spasticity with dystonia would be dystonia is something that is exacerbated with certain voluntary activity or merely thinking of certain voluntary activity or response to a voluntary activity. And it is variable and it depends on certain emotional states. For example, a child with dystonia may only have or may only present with spasticity when the child is sleeping. Whereas when the child wakes up from sleep, you may see the dystonia coming into light. Whereas rigidity is something which is more persistent versus dystonia, and the posture and the tone may be variable, but not as variable as you see in dystonia. Now, diagnosis of DCP. So when to make a diagnosis of dyskinetic cerebral palsy, of course, one would look for movement disorders. So movement disorders in cerebral palsy, a cerebral palsy child with the superimposed movement disorders would designate a child to be called as dystonic cerebral palsy or dyskinetic cerebral palsy. So the commonest movement that we tend to see would be chorea ethitosis or dystonia, and majority of people would like to combine chorea and call it as chorea ethitosis. I'm more fond of calling children with choreiform dyskinetic CP or a dystonic dyskinetic CP. They're typically recognized from the age of 2 years old. Majority of these cases with DCP do not come into light, do not present themselves before the age of 2 or 1.5, because the early presentation will always be increase in tone, hypertonia, right? And most of us diagnose them as spastic CP. And the other aspect to remember clearly here would be, it's okay, it's fine for us to change our diagnosis or to amend the diagnosis as the child grows and as the child evolves, as the clinical symptoms evolves. So many of the cases tend to present with the movement disorders or evolve to become more of a form of a dyskinetic CP as they grow older. As you can see that the diagnosis of movement disorders in cerebral palsy is not straightforward, and there is a delay. Late onset movement disorders can range from somewhere between as early as 1 year old to 32 years old, where they become an adult or adolescent. And involuntary movements or dyskinesia tend to affect all 4 limbs almost equally, at least in the stage of when they are evolving until at the later stage. They're usually misdiagnosed because the misinterpretation of clinical signs is usually there. Now, why is there a misinterpretation of clinical signs? Now, for example, when you see a child with what you call with the plantar response or a spontaneous plantar response, immediately what we would be inclined to call this is Babinski's response or status Babinski. But majority of the times in children with cerebral palsy, they may not be Babinski's sign. As a matter of fact, they may be a dystonic posturing. So, sometimes we call it as a striatal toe. So one of the tricks that I like to usually use is when I see a child with Babinski sign or a spontaneous Babinski sign, I would like to implement the Chaddock sign. So in a child who has got Babinski sign, which is spontaneous Babinski or a striatal toe, a Chaddock sign may bring out a Babinski sign and not the striatal toe. And the other aspect of misinterpretation or confusing would be between rigidity and spasticity. It's not easy for us to differentiate between spasticity or rigidity, especially in the later stage, when the spasticity has become more, evolved at a later stage, and the child has developed certain orthopedic complications or secondary changes such as contractures. And the other aspect why we tend to miss movement disorders in children with cerebral palsy would be the fact that, as I just mentioned before, movement disorders, in majority of the times, tend to show variability depending on the state, whereas spasticity is unchanged. And one of the reasons why we misinterpret or we do not make a diagnosis of dyskinetic cerebral palsy in the early stage would be the overlap between spasticity with hypertonia, spasticity with rigidity, spasticity with dystonia and chorea for movement. And of course, one of the major aspects of last but not the least is the familiarity in making a diagnosis of dyskinetic CP or recognizing movement disorders in children with cerebral palsy. Now, neuroimaging, just one slide. I would say it's something very essential, almost compulsory for me at this point of time to help us to delineate the etiological diagnosis, to gauge the extent of injury, to improve our counseling, and probably to a certain extent predicting outcome, which may not be the case in all the patients. Plus, in a case where neuroimaging has been done, and this is a case of cerebral palsy secondary to HIE or suspected to be cerebral palsy secondary to hypoxic ischemic encephalopathy, a normal MRI should raise an alarm to us that there could be some other cause. In a child with dyskinetic cerebral palsy, it is important to find abnormal signal or abnormalities in the thalamus, basal ganglia, in any part of the nigrostriatal pathway. In the event of not finding such such neuroimaging signs, it's important for us to look for other possible etiological diagnoses. Okay. Now, movement disorders in cerebral palsy. It's a spectrum, right? Of course, going through literatures, you may get certain ideas that certain movement disorders are more common, but till date, majority of the descriptions are based on dyskinetic CP and dystonia in cerebral palsy. However, the crux of the reports and the crux of the point here is majority of the cerebral palsy cases with superimposed movement disorders are associated with hypertonia. Now, although there exists a good definition and consensus on how to recognize dystonia, chorea, rigidity, or Parkinsonism in children with no cerebral palsy or non-cerebral palsy children, there seems to be lack of knowledge or lack of experience among most of us in trying to create a definition or coming to a consensus on how to diagnose a children with spasticity with superimposed dystonia. Should it look the same? Should it feel the same? Should it present the same way? Majority of us presume it to be so, but I think, our knowledge is still lacking in that aspect. 10% of cases have been reported where children with dyskinetic cerebral palsy do have superimposed other forms of movements, which are tic-like. Some of them are tremor when they're superimposed with what we call dystonia. They're called dystonic tremors or stereotypies. Now, how do you wrap your head around this trying to characterize, look, this child has got dyskinetic CP, he's got spasticity, but the other majority, the other major movement or predominant movement that is recognized is tremor. But you have not diagnosed or you have not recognized the dystonia in that child. So it's not easy. It's not an easy task. So the way that I would like to put it forth would be that if a predominant movement is recognized in a child with cerebral palsy, just take it as it is, and a serial assessment, a serial observation and review would probably bring into light a certain form of other predominant movements which will be helpful for us to guide our management. And most of the papers and most of the experiences have noticed that myoclonus is not observed. Now, if I would like to throw a question to the experts and probably Dr. Biju, why is it in a patient with dyskinetic cerebral palsy, we don't see myoclonus? We do see dystonia, we do see chorea, some serotypy sometimes, rigidity at times, but why not myoclonus? So we'll leave the question to the last. So majority of the movement disorders that are seen in DCP are classified. 75–80% have been classified. The rest are still yet to be classified. Now, why is dystonia important in cerebral palsy and how are they defined? Again, the definition of dystonia is still the same, defined by involuntary maintained contraction of agonist and antagonistic muscle, leading to abnormal posturing, twisting and repetitive movements, or sometimes tremorless movement, which was recently added. Why is describing or why is recognizing dystonia important in patients with cerebral palsy? First, dystonia causes great amount of pain. And in my experience, I've found that majority of the patients with cerebral palsy with dystonia, dyskinetic cerebral palsy, suffer from more pain than children with spasticity alone, unless the child who has got spasticity is suffering from GERD or hip dislocation. If a spastic child does not have GERD, does not have hip dislocation, the extent of pain that they suffer from is nowhere near or close to a child who's got dyskinetic cerebral palsy, where they're twisted, and they're bending, they've got opistotonic posturing and so forth. And dystonia is important because it's functionally disabling versus spasticity. And of course, the treatment differs. The approach differs. The pharmacological agent that may come to your mind to be started as one of the first agent or a second agent differs when you are considering a case of a child with spastic cerebral palsy versus a dystonic or choreoathetotic cerebral palsy. And as most of us know, and it has been to a certain extent convincingly debated, that in a child with dystonia per se, irrespective of dystonic cerebral palsy or not, treating dystonia is very much time sensitive. A child who has received early stages of treatment, early treatment, may improve faster, may improve to a greater extent compared to a child who has been recognized late and treatment has been implemented late. One of the last points why I would stress that recognizing dystonia is of great importance in a child with suspected cerebral palsy or dyskinetic cerebral palsy would be a child with early onset dystonia. Although on the background of cerebral palsy, it is important to think of some other causes which may present like cerebral palsy. Now, how are we going to look at cerebral palsy in future? This is where I'm probably going to speak or shift gear to speak about the genetics in cerebral palsy. It's important for most of us to revolutionize the way we think, to amend the way we think. Cerebral palsy is just a diagnosis of a state. It is not a disease. It could be designated as a syndrome, but it's not a disease. It's not an etiological diagnosis, such as epilepsy. A child with epilepsy may have multiple forms or, variable forms of diagnosis, etiological diagnosis. Hence, CP, cerebral palsy, I humbly would like to throw this out there and echo this out. It should be a phenotypic diagnosis, not an etiological diagnosis. So any child that we come across with cerebral palsy, we suspect with hypertonia and motor impairment, and we think, this child has got high risk of cerebral palsy, or this child should be called as cerebral palsy, should be designated cerebral palsy, we should think of the etiological diagnosis. Look carefully, look keenly with a keen eye. Don't be skewed just because someone else has diagnosed as cerebral palsy. Don't throw them into a wastebasket. Look into the clinical history, look into the neuroimaging findings. Are they consistent? To see what is the etiological diagnosis. And majority of us are now moving towards genetic diagnosis, getting genetic testing done for patients with cerebral palsy who we think may harbor a different etiological diagnosis rather than prematurity or damage of insult from prematurity or hypoxic ischemic encephalopathy. And bear in mind, there are this, major group of children or chunk of children or adolescent or adult who have the misfortune of missing the genetic age, where genetic testing is easily available, WES and WGS is easily available, and we can get the test done with the so much lower cost at this point of time. So these children, these adolescents, these adults who have got dyskinetic cerebral palsy, or even cerebral palsy for that matter, should be revisited. The etiological diagnosis should be teased out. So I hope in future, maybe in a decade or half a decade, the diagnosis should be SHIP, cerebral palsy XX mutation stroke syndrome. Now, why genetic diagnosis matters? So in majority of the papers and experiences, approximately 30% of patients with cerebral palsy diagnosis have some underlying or underpinning genetic etiologies. This could be something with some diagnosis which is evolving, which may overthrow the child from a CP diagnosis per se, because a cerebral palsy diagnosis can only be implemented when it's a non-progressive insult. But a genetic diagnosis helps you to focus further on how to approach the child. Now, even in children who have got the risk factors such as prematurity, 8% of them have been found, somewhere odd 8% of them are found to have certain genetic etiologies. Now, this helps in some of the cases. I'm pretty sure that most of us have been thrown this question, especially when the genetic test requires some form of coughing out of money or some financial aspect. How does this change the management? How does this change the outlook? I mean, I must say, to be very humble enough, that at this point of time, probably 8 to 10% of the children may benefit from management change or alteration in the child's medication, whereas the rest may not be, but it is important to prognosticate the child. So whole exome sequencing has got a pickup rate of about 23 to 25%, and CMA, microarray, may have slightly lesser. So I would recommend, if you're going for a genetic testing in a child who has got cerebral palsy or cerebral palsy-like or dyskinetic cerebral palsy presentation, to go for whole exome sequencing if it is available. Now, what are the red flags for genetic diagnosis in dyskinetic cerebral palsy? Of course, in the history, if there's an absence of any form of perinatal risk factors, and if there is a good family history of someone who has got a CP-like presentation or any form of neurological deficit associated with hypertonia, when there is an iffy history of slightly progressive or regressive cause, although this could be challenging, as majority of our children with the dyskinetic cerebral palsy, they may seemingly present in a more progressive way. So rather than being progressive, they are probably evolving, and their clinical signs and symptoms are actually worsening, maybe because inability to get a proper adequate treatment. And when you see a child with a diagnosis of dyskinetic cerebral palsy, but the imaging is normal, and again, as I mentioned and stressed before, if you come across a child with hypotonic cerebral palsy, I must confess and say that majority of the cases with what I call symptomatic cerebral palsy, not the cryptogenic or idiopathic ones that I've seen, I've not come across even one with hypotonic presentation. So any child who comes in with a cerebral palsy-like diagnosis or cerebral palsy diagnosis slapped on them, but they are hypotonic, I'm biased or skewed to think that most likely this is not symptomatic. Now, whenever there is a mismatch between a perinatal history, brain MRI, or any form of neuroimaging, or the motor phenotype. Now, for example, if you come across a child who has got a diagnosis of cerebral palsy, and the risk factor is prematurity, an MRI may show certain form of what you call prematurity associated injury, but the presentation is more of a dyskinetic cerebral palsy. This is something that should alert us to think about, is there a possible other etiological causes that we are missing in this child, for example. And then in part of the assessment for children with dyskinetic CPM plus minus cerebral palsy will be, these are the few scales that I tend to use, I'm keen to use. HINE, it's a fantastic scale. It's time consuming, but it's very pictorial, representative, and helps you to predict a child who may have risk to develop cerebral palsy. Fractals, general movement, assessment. I rarely use them, but when I use them, it's quite useful in certain cases. GMFCS, most of us are very much familiar with it. And of course, when you see a child with a dystonic cerebral palsy or a child with a dyskinetic cerebral palsy, Berg-Fun-Marston dystonia rating scale, one of the best scales and something that I'm very familiar with. But I must say that BFMDRS may not be practical to be used in every child with dyskinetic cerebral palsy, especially when the predominant hypertonic state is spasticity with superimposed dystonia. So I find it a bit difficult to use this scale. But Barry Albright dystonia rating scale is something which is a scale which is very easily used, especially in children with cerebral palsy, even though if they have superimposed other forms of hypertonic state. And dyskinesia impairment scale, one of the best scales, can be used for those children who present with dystonia in cerebral palsy as well as choreiform cerebral palsy. And then the last, dyskinetic cerebral palsy functional impacts scale, which is basically to see how, or to assess and gauge how much does the dyskinesia impact the activity of the daily living. Now, talking about dyskinetic cerebral palsy and mentioning again the fact that if there is a form of mismatch, or you are not convinced enough that this is a case of dyskinetic cerebral palsy secondary to the common causes of hypoxic ischemic encephalopathy or prematurity with the basal ganglia stroke, then think of first a few impersonators which may present or mimic in this way, at least in the early stages. Although as the diseases progress, you may be able to pick them up singularly and then make probably a good, accurate or good enough the clinical diagnosis and go for a genetic testing. But in the early stages, they may be very much confusing. So think of glutaric aciduria. And of course, neurotransmitter disorders should not be missed, because in some of them, early installation or early usage of dopamine or dopamine agonists may basically change the patient's life and the clinical cost tremendously. Of course, NBIAs, may present, and the few cases of NBIAs, the Pla2 G6 and the two cases of PANG2 that I've come across did present as cases of cerebral palsy, dyskinetic cerebral palsy, and their early stage MRIs were plumb normal. No evidence of deposition, no evidence of infarcts, no evidence of abnormal signal, no evidence of putaminal atrophy that you tend to see in children with the profound hypoxic ischemic encephalopathy. So that is probably one of the things that made me aware that this child, or this child with the dyskinetic cerebral palsy or presenting as dyskinetic cerebral palsy, may actually harbor some other diagnosis and not a symptomatic case. Leach-Nyhan syndrome, yes, they may impersonate as cerebral palsy in the early stage, especially the choreiform or choreoattitoid cerebral palsies, organic acidurias, Lee disease, mitochondrial disease, and creatine deficiency syndrome. I had a case who we diagnosed after many years because we were initially thinking of some form of dyskinetic cerebral palsy, some form of a child with a neurogenetic disorder, but we couldn't pin our finger on it. And ADC Wi-Fi associated syndromes may present as dyskinetic cerebral palsy, especially the hyperkinetic ones. Now, in future, how are we going to classify children with cerebral palsy? Now, this is how I tend to look at a child when a child with cerebral palsy, especially dyskinetic cerebral palsy, presents to me. Either symptomatic, meaning I know the diagnosis, prematurity associated with basal ganglia stroke, or a child with what you call hypoxic ischemic, term hypoxic ischemic encephalopathy, or a child with some form of cerebral insult, which has occurred in the first 2 years of life, post what you call meningitis or encephalitis, post-traumatic brain injury, and henceforth. Or a child who I think there's a secondary cause, but I do not know the etiology yet. Cryptogenic and of course idiopathic. So I think by training ourselves, imposing such what you call approach by designating them as possible symptomatic or cryptogenic idiopathic, we are training ourselves to be more careful and to be more alert on the possible etiological diagnosis for cerebral palsies. One of my, I think it's my last slide, right? Before I end my talk, I would like to just put up this slide because I think most of us or some of us who have moved away from focusing on cerebral palsy, thinking that most of these kids do not live long, and we may not want to provide too much because it doesn't make a difference. I think most of us are wrong. Now, this is the good old customary Hutton's diagram that we have been using for many years, where majority of the kids with cerebral palsy and severe functional impairment do not live more than 10 years or the first decade. But now there are many studies to show that children or adolescents with mild CP, 90% or 80 to 90% odd of them live a normal lifespan. In 1983, as one of the studies showed that 50% of 4-year-old children who did not lift their heads in the prone position and tube fat lived only up to about 10 years, the first decade. This is one of the, what you call good old adage that we tend to follow, that, if the child has got a GMFCS 4 or 5, the child probably doesn't live more than 10 years old. But in 2010, they revised it and they realized that the median age of death is actually 17 years. And I think this median age is going to keep increasing as we provide better care and the recognition of complication, the recognition of movement disorders is more efficient among us. And by Brooks et al., more than 40% of patients with cerebral palsy tend to live as long as 30 years old. Now, the summary. Cerebral palsy is a syndrome of heterogeneous etiology. Please remember that. Dyskinetic cerebral palsy have been increasingly recognized and reclassified etiologically. And this is something that I've been doing in the past 5 to 6 years, keenly doing in the past 5 to 6 years. And keep in mind to recognize movement disorders in cerebral palsies and dyskinetic cerebral palsies and the red flags for etiological chase. Thank you.
Thank you, sir, for that enlightening presentation. Should I first ask questions or the expert opinion?
Nee. Yeah. Ekta, we'll have expert to give opinion first. Yeah.
Okay. So first, Dr. Biju, do you have any comments upon the presentation before I move to the rest of the expert? Sir has put forth a question for you also.
No, it was great. Thanks, Dr. Taj. That's you've raised very pertinent questions, particularly in how we address the cerebral palsy and its classification. And it's a very timely talk as well, because we still, the practicing clinicians find it difficult to differentiate when it comes to hypertonia, to differentiate the dyskinetic and the dystonic aspects in it. because obviously it makes a big difference in terms of how you manage these children, isn't it? So it's very important. And we use the hypertonia assessment tool, the HAT tool, because like you said, the BMFDRS, yes, it's a fantastic tool, but as you know, it's been developed and validated for primary dystonia in adults, mainly as an outcome measure for DBS. And so, although we adopt it for CP children, yes, there are limitations in a practical setting. As you mentioned, the dyskinesia impairment scale, fantastic tool, probably the best, because you can differentiate between dystonia and choreoathetosis, as you said. But again, you know, in a busy clinic setting and with the therapist, sometimes we rely on the HAT, hypertonia assessment tool. Sometimes what were these situations where sometimes we get caught out is when you have spastic dystonia, as opposed to purely dyskinetic CP, where you have the spastic co-contraction. You know, the typical poster of hemiplegic children with the elbow flexed, pronated arm adducted, isn't it? And then at night when they sleep, it's fine. You can do whatever you want with it. And that to me is the spastic co-contraction. And sometimes people do mistake it for like dystonia. So it is still, it gets very tricky still in the equinovarus posturing, for example, the spastic co-contraction between the tib and the cuff muscles, and it gets very tricky. So very timely talk, and enjoyed it thoroughly. Thanks, Dr. Dash. Thank you.
Thank you, sir. Dr. Carmen, may I have some comments from you, sir?
Yeah, thank you. First of all, it's a great lecture. Thank you first of all. It was so teachful. In your last slides, you emphasized that the overall survival is increasing in CP patients. At that point, the improvement of quality of life is also important. At this point, you emphasized the importance of pain. The recent studies show that the pain is more common in dyskinetic CP patients than other types of CP patients. Thanks to you because of your emphasize the importance of pain. The relief of pain increases also the quality of life. Thank you very much.
Thank you. Thank you.
Thank you, sir. Dr. Farida, can you please unmute yourself and please make a few comments on the presentation? Ma'am, you're muted.
Here I am.
Yes,
so thank you very much. I really enjoyed the lecture. The different aspects that Dr. Tajuddin took up. We see a very large number of cerebral palsy in our clinics. And as very rightly said, the hypotonic CPs and the dyskinetic CPs, they always give you a feeling that they may not be CP. I don't know why they give us this feeling, but nonetheless, these two types of CP, they always put you to think again and again, could this be something else? So I think all of you would agree that in these areas, we do think beyond the obvious. As far as the genetics is concerned, so yes, genetics is going to reveal a lot more. I personally have had a number of patients who were labeled as CP. They came to me late, and then trying to deal with parents who need an answer. Usually this is what happens with me, which pushes me towards genetics, but in a number of times it has been myself as well who is not satisfied with the diagnosis of a CP. So one turned up as Batten's. Ultimately, when we did send the genetics, it was a breakthrough, and I was so amazed. How could I not pick up Batten's? And it was a CP throughout, and then 8 years old turns up as a Batten. So I really enjoyed the whole thing. We really need to take the cerebral palsy forward. We need to look into the classification. We need to define these further, because with time we'll need to make it a little more dynamic. The old definitions, the old classifications, they really need to be modified to the present day. So thank you very much.
Thank you. Thank you.
Thank you, ma'am. Dr. Mary, please, your comments.
In Kerala, we find that dyskinetic CPs are very big children. The smaller children, among the smaller children, we do not find so many dyskinetic CPs. And whenever we find a dyskinetic, and it turns out to be ADC Wi-Fi, GNA01, or KMT2B. And as Dr. Taj has rightly pointed out, we should look at the genetics, because here, at least in our country, in our state, we have these high-end port therapy units, and we are not having so much hypertension.
Thank you.
Thank you, ma'am. Shifali, ma'am, any comments from your side?
No, it was an excellent talk. We'll have a Biju's talk, and then we can have discussions and the Q&A, because the Q&A will never end. So let Dr. Biju speak first.
Sir, but I think you have raised a question for the group. At least give us that answer before we go into sir's topic. Otherwise, that would keep crawling into our mind again and again. Why don't we see myoclonus in...
I see Dr. Vivek's comments as well about
Yes.
myoclonus. Now, I mean, I don't know the answer, but I think Dr. Vivek mentions that they do see myoclonus but that's a different context completely. That's not the question I think Dr. Taj was asking, because that's the context of cortical myoclonus in asphyxia. But I don't know, Dr. Taj, like you made me think. I suppose I was thinking, like if you need myoclonus, be it cortical or subcortical, whatever we call it, the oscillations, whatever, you need a circuit for it to continue, isn't it? The cerebello-cortico-thalamo circuits. I suppose if these circuits are not intact in these children, then perhaps there is no spread of these oscillations from the cortex elsewhere, and hence we do not see myoclonus. I don't know. This is just me beating on the
I mean, for us to have a dystonia or chorea, the corticostriatal, thalamic, even rubral and cortical tract should be impaired. Somewhere around the pathway, there must be certain disruption, including even the myoclonus is actually involved in a certain pathway, because it comes from the cortex and subcortical region. And of course, some of them are rubral. One of the questions that came to me was, why don't we see myoclonus in dyskinetic CP? I have no answer for this.
No, but actually you are right, what Vivek is saying is also right, but that we see because of asphyxia. But in
Yes.
CP, when you're saying, actually, I never thought of it before, but actually if you're just remembering all those CP, all this dyskinetic CP, yes, you don't have myoclonus in that.
I've seen tics I've seen serotypies, I've seen what you call tremor, dystonic tremors. I've seen some of them which are Parkinsonism, but not myoclonus, which I don't know why.
If anybody wants to say something, please raise your hand.
Yes,
you can speak. Anybody having any idea about the possible or anything, And Vivek, even if you want to say, you can raise your hand, and Asmita will pull you for a panelist. Vivek, if Asmita, can you send Vivek the panelist thing?
Yes, ma'am.
Vivek, please accept the panelist thing, because you are, it'll be nice to finish it off, because Ekta is insisting on clearing this issue before going to Botox.
I don't think we can clear the issue. We should move forward.
Yeah.
I was hoping you have the answer. Therefore, I told first get the answer. Never mind. So the next talk is by Dr. Biju. It's on botulism toxin and the management of children with cerebral palsy. Over to you.
1 second, Ekta. Vivek is in the panelist. Vivek, we'll give you 2 minutes only, because she's already announced Biju to share. Please make your comments. Vivek. Dr. Vivek Jain, you are a panelist. Can you?
His audio is not connected, probably.
Okay, maybe after Biju's talk.
Oh, yeah,
And you
there
can.
he is.
He's there. Hi, yeah. Hi, yeah. Hi, Vivek. Yeah, you're not audible. Please unmute him. Asmita.
He is
Asmita,
unmuted.
Vivek, you are unmuted. You want to log off and log in again or something? You can
Sir,
log
please
off and
remove
log
your
in again.
Please remove your headphones. You are not connected with the audio. Please remove your earphones.
So your audio is not connected. You need to remove your earplugs. The
I don't think
earphone.
Vivek can hear.
Okay, Dr. Biju, you start sharing the screen. Where meanwhile, Ekta, you type that he can speak for his comments
Yes, ma'am.
after Biju's talk.
Yeah.
Yes, ma'am.
We can even go in between because I think we'll make it very
No,
uniform.
no. In between Botox, don't get myoclonus. Yeah.
Okay, let me try and share Ekta.
Vivek, can you hear us now? No. Okay, Biju, you go ahead.
So we heard about cerebral palsy, fantastic talks, and this slide is pretty self-explanatory. We know all about the upper motor neuron syndrome, which cerebral palsy is, but it's important to know that there are positive features and negative features. Positive features are the spasticity, hyperreflexia, and the co-contraction that we've been talking about. And we know that, over the years, we have put so much emphasis on the management of these positive features of an upper motor neuron syndrome, but it's very important to
Sure. No, there's not.
remember.
No, there's not much to say. It's just one or two observation. No problem.
Yes, Vivek, go on.
Should I speak? Right. I'm sorry.
Yes. Yeah. No, Vivek, go on.
Oh, sorry, Biju, for interrupting you in between.
No problem.
So there is a very interesting observation.
Oh, it's going again.
So we can't hear you again. Vivek, sir? I think some problem with his audio.
I think it's audio, with the audio. Yeah.
It's okay.
We'll
I had called
continue.
him when I was talking to him on the phone. He was audible. Yeah, I was talking to him and he was audible. It's okay. You please continue.
Continue. So it's important to remember that the like the positive symptoms, the negative symptoms, which is the balance, the weakness, and other comorbidities are also important. And again, especially the positive findings and the negative findings that we've been talking about.
Hello.
So essentially what happens is it's a vicious cycle, isn't it? Because you have an abnormal muscle activity and balance resulting from these motor neuron findings, which changes the biomechanics. So there is increased muscle and connective tissue adaptation, which results in decreased muscle growth. It results in muscle contracture, which subsequently causes changes to the skeletal framework, which subsequently again causes the abnormal muscle activity and balance. So this vicious cycle goes on. And it's important that we break this cycle, and hence the reason why it is also important to address spasticity. Now, the muscle architecture in terms of why it's important, move on. The co-contraction that we see is very important because co-contraction of the calf muscles, for example, the co-contraction of the hamstrings, very important. So the point is like it is important to address the spasticity and the co-contraction that you see associated with spasticity in order to improve function. This is quite nicely shown in this video. I don't know whether you can see that the co-contractions of the hamstrings, which makes it impossible for the child to when it tries to sit, it just drops onto the floor as opposed to like the proper way a child would sit. Again, just shows to highlight that in order for the gait function and for balance, for proper stance, we have to address these issues. So how do you manage this increased tone? You might all be familiar with this cartoon, which depicts the various interventions, dividing into focal interventions as opposed to general interventions, and then reversible and permanent interventions. So we know that the oral pharmacotherapy, deep brain stimulation, intrathecal baclofen are general treatments which are reversible. Selective dosal rhizotomy, a permanent procedure, orthopedic surgeries, and here comes Botox. So it is a focal treatment. At the same time, it is a reversible treatment. Now, in the last decade or so, botulinum toxin for the management of spasticity has become an international standard treatment in the management of pediatric hypertonia. And in the UK, it's been adopted within the evidence-based, the NICE guidelines for spasticity management. And in fact, the botulinum toxin therapy remains one of the very few interventions for cerebral palsy where there is a sound evidence base. But there is a caveat here, because and this is not a problem with the studies on botulinum toxin. It's a problem with studies on CP as a whole, because, like I said, if you look at the literature going back, the last 20, 30 years, the focus has always been on the management of spasticity, and the outcome measures on what these studies have been done was, again, whether the spasticity had improved or not. The focus has not been on function. The focus has not been on activity. The focus has not been on participation, which we now know are the key elements on a child with disability. So although the evidence is there on botulinum toxin, the evidence is on the short-term outcomes. Again, as I said, related to the body structure, which is only one aspect of the International Classification of Functional Disability and Health, the ICF framework. The activity and participation measures have been, outcome studies have been lacking, but things have been changing. So over the last, few years, there's been increasingly, when you go for conferences, you see increasingly posters and oral presentations and papers on this. So the evidence for for botulinum toxin in cerebral palsy remains a very effective option in the management of hypertonia. So how does it work? So we know that what we are essentially doing is a reversible chemical denervation of the muscle, and it leads to a dose-dependent decrease in the muscle spasticity and strength. Now, but important thing to remember is that it does not selectively only manage spasticity, or it does not selectively only stop dystonia. Essentially, it is a chemodenervation, but the driving factors for spasticity and dystonia, as we know, are all central. So when the botulinum toxin is injected directly into the muscle in minute concentrations, it blocks the neuromuscular transmission by binding to the receptor sites on the motor nerve terminals. So what does it do? It inhibits the release of the acetylcholine neurotransmitter. but it does not affect either the synthesis of acetylcholine or the storage of acetylcholine. What it does is it binds to the transmitter and prevents acetylcholine from being reversed. So it does not affect the number of synaptic vesicles, or it does not affect the conduction of electrical signals down the nerve fiber. No. And we know that the clinical effects we begin to see first few days after the injection, 24 to 72 hours, peaks in approximately 4 to 6 weeks, and the effect, particularly the functional effects that you get from it, can often last for several months. And the average duration is around 4 months before the neuromuscular junction is re-established. But the functional benefit that you get from it will, you can continue to make gains over the next 12 to 18 months. Very important point to note. Now, the botulinum toxin A license, classically we say that the indication, the classical indication is for a dynamic spasticity which interferes with function, particularly in the dynamic equinus foot deformity that you see in ambulant children 2 years of age or older. And that too, it should be done in specialist centers with appropriately trained personnel. So that's the conditions of the license. So this is the literature which supports the use. It temporarily reduces the overactivity of the spastic muscle. It prevents co-contraction by giving an opportunity for the therapists to work on the agonists and antagonists, and thereby the motor learning, sending like positive vibes back to the brain to facilitate an improved motor pattern. And in addition, it also encourages improved longitudinal growth in spastic mind, which is also majorly affected in cerebral palsy. So the classical indications in the ambulant child and the ambulant older child. So the idea is where you have an increased dynamic spasticity, and also in the older child where there are residual contractures, but the dynamic component is less. Both these instances, the GMFCS 1 to 3, the Botox would be an indication. In non-ambulant child, for example, in GMFCS 4s and 5s, the indication would mainly be palliative, or it would mainly be to address pain, as Dr. Prasad was pointing out, because that's a very important fact. In fact, when you look at management of spasticity, if you look at the old ladder approach that we use, the bottom line is to remove any incriminating factor, i.e. remove pain. Very, very important. And this is again another situation where botulinum toxin is a major weapon in your armamentarium. So particularly in those children where surgery is not an option, and addressing those muscle spasms. And also in children who we can't use orthosis because of failure to tolerate them. Again, it's very important. It makes ease of care, and sometimes this can be the significant life-changing intervention for these children, be it cleaning the armpits or cleaning the groins or making it easy for carers to change nappies, etc. So the dynamic equinus that we've been talking about, and this has been well studied. We know that the botulinum toxin is very effective in this, but very important also to note that the functional benefit that you get is when you combine the botulinum toxin therapy with physiotherapy, and without the help of orthotics, and in some cases casting as well. So this would be the classical situation where you would be your ideal candidate for botulinum toxin therapy. The in dynamic equinus, we know that there are a small number of children who are fantastic responders, while majority of children do respond in one way or the other, and there's always a small number of children who do not show much response. And we know that with repeated injections, sometimes we tend to see a decreased efficacy. Now, the jury is still out on why that is the case, and you can think about so many reasons why botulinum toxin does not seem to work. It could start from even an over expectation from the side of the families or from the caregivers to the other extreme, where the child has developed a genuine tolerance, of the to the toxin, i.e., by the generation of antibodies. So, but we do see that perhaps too frequent toxin injections, too close together, do tend to produce less effect as opposed to stretched out toxins. But in dynamic equinus deformity, it's still a very useful intervention. As I alluded to in the beginning, what we don't know for certain is what are the effects long term, i.e., what are the positive effects long term, and also what are the negative effects long term. Because if you speak to orthopedic colleagues, they would say that when they operate, when you look at a muscle, they can tell with the naked eye whether this muscle has had several injections of Botox or not. So it certainly does affect the muscle fibers, but still the literature on it is not that abundant in terms of coming to any definite conclusions. There are also situations where you use multi-level lower limb injections, particularly when the dynamic spasticity exists at multiple levels. But again, what's important in these situations is the careful assessment of the muscle selection in terms of the muscle selection, and also to set clear goals. The challenge is often the children are small, they have small body weight, and we are limited by the amount of toxin that we can use. So if you inject too many muscles, you are spreading it out a bit thin, and perhaps you won't get the desired effect. Of course, the painful multiple injections is associated with more pain. And again, whether by in multi-level spasticity, whether pushing along with toxin, whether it actually takes away the need for surgery at the end, or whether we don't need surgery at all. Again, the jury is out on that, because most of these children will need orthopedic interventions at some point or other. But if we can reduce the need for it, and if we can delay the need for it, and that's very good. So that's also helpful. So in summary, we use it in GMFCS 1 to 3 to improve gait, to improve function, participation, tolerance of orthotics, reduce pain. In GMFCS 3 to 5, again, to assist with postural management, to facilitate care, reduce pain and discomfort, maintain the ranges, and most importantly, to prevent further deterioration. And when it comes to the upper limb also, again, the indications are more or less the same: to improve posture, improve function by reducing the abnormal posturing, maintain and improve the active range of movement, facilitate participation, tolerance of orthotics. So the indications, when it comes to the upper limb and the lower limb, are more or less the same. So we've talked about this. Botulinum toxin, and we know that there are other situations where we use botulinum toxin, particularly for drooling and also for the neuropathic bladder, which is not our focus today. So this would be a situation where, like I said, GMFCS 4 and 5 children, where toxin can be particularly helpful in addressing pain and cares. Like, for example, the toxin to the pectorals in this girl would be very effective in addressing care issues. In children with progressive neurodegenerative conditions, as like this young man with Leishman hand, again, it can be pretty helpful in addressing the spasticity and and here in this case the dystonia as well. The upper limb posturing, as you can see here, this would be another so the image, the video on the right was post toxin. As you can see in the upper limb posturing, which interferes with function. Particularly when she's walking, you see the posture. When she's concentrating on something else, and you can see on the right where the toxin has made a big difference in terms of the affecting the arm posture. So just an example to show how these things can be helpful. Another indication is, and this is impeding so much on function. You can't even pass through doors without the arms getting stuck, and also there'll be huge trouble when trying to change his top as well. I mean, there are significant differences pre and post toxin in terms of trying to maintain the arm posture. This is here with the post toxin. Much more easy for caregivers to help him. So in terms of the optimal age, we know like we tend to inject from 2 years onwards, but I know colleagues who have done at slightly younger age, but 2 seems is sort of our youngest age that we would try toxin with. But we would normally ideally go for slightly older, maybe from 3, 4 onwards. And we know that as given the vicious cycle that we talked about, the longer we leave it, the muscle contractures and other issues then come up, and then the toxin becomes less effective. And this is a nice cartoon from Peter Rosenbaum's book, which shows the various interventions: orthopedic intervention, intrathecal baclofen, botulinum toxin, oral medications, orthosis, and functional therapies, how it changes from GMFCS1 to 5 and across the age. So again, it shows that across the various GMFCSS1 to 5, toxin still remains botulinum toxin still remains a very effective intervention for every level of severity. It's very important. The limitations are, again, it is a focal treatment, as we mentioned. It is reversible. Meaning we need repeated treatment. There are issues with diffusion and systemic problems, etc. And the other limitation is obviously, like what I said, we don't know what are the long-term indications on the muscles which have been injected. But what are the possible goals? So in the upper limb, we would use improve reach, reduce the thumb in palm, reduce the flexion posturing of the wrist and fingers, to reduce the equinus posture, reduce crouch, reduce the scissoring gait, improve tolerance of orthotics. And what would be the participation and activity to improve the endurance, reduce the frequency of falls, reduce pain, improve ease of care, improve the cosmesis. But who would be not the ideal candidate for botulinum toxin? So any child with severe muscle weakness, and which stays without going that if you've had a previous allergic reaction to Botox, no. Concurrent aminoglycoside treatment is a relative contraindication. We have injected children with who had bleeding disorders, but you just have to be cautious in that case. I know if factors need infusing, then those children should have them, and it should be well coordinated with the hematology team. And also the generalized spasticity, because we know that limitation is that it is a focal treatment. And if there are fixed muscle contractures, then it's highly unlikely that the toxin is going to make any difference. If there is marked bony deformity, also you have to be careful. And very, very important, the toxin on its own is not going to make any difference, because it is the therapy and the other adjunct treatments which make the difference. And if there is no commitment from the family for ongoing therapy, or if we don't have the necessary establishment in your facility to have access to such therapies, then perhaps you shouldn't do botulinum toxin just for the sake of it, because you are not going to get the outcomes that you originally wanted. In terms of the adverse effects that we tend to speak to the families while getting consent for the procedure is mainly, of course, it's an IM injection, so you would expect some soreness at the injection site. But generalized fatigue and flu-like symptoms are very, very common in these children, but nothing which wouldn't go away with a bit of paracetamol. And the transient weakness, which also is very important to remind these families, because some of these children are maintaining the upright stance using this spasticity, and sometimes injecting those muscles might make them big, albeit for a short period, which can seemingly look as if the child has been taken off its feet, which can be sometimes quite scary for the parents. So you need to warn these parents. And you will factor all these things in when you make your muscle selection. Like you're never going to inject the gastrocs and the soleus on both sides, for example, and when you're injecting somebody for the first time, you would tend to go with a smaller dose than you would want to. So all these factors are quite important. And as I said, the resistance to future injections, so try and space out the injections. Like we tend not to inject no more frequently than every 12 months, unless it is a GMFCS 4 and 5, where we are doing it for palliative reasons. They also tend to get bladder instability, a bit increased frequency, but something which is not a major concern. The diffusion of the toxin to extra sites where we didn't want to inject is a potential problem, particularly if we inject around the neck. And if you look at the product literature accompanying the toxin, they would say like even there are fatalities from aspiration pneumonias and from dysphagia caused by diffusion of toxin into the surrounding areas. We talked about this in terms of long-term efficacy, but there is very little evidence at the moment, but improving the gait is a definite indication. And also reduce the frequency and the incidence of surgery in these children. Very important that the post injections, the therapy and the orthotics prescriptions are very important. Now, who should be injecting? Now, I know this varies from country to country, but essentially it is a multidisciplinary undertaking, and it should be done in a team who comprised of professionals with experience in neurology and musculoskeletal assessment, and there should be facilities for ultrasound or electrical muscle stimulation to guide the injections. There should be facility to address the pain and keep the child as comfortable as possible. The team should ideally include a physiotherapist, and if you're injecting the upper limbs, then an occupational therapist as well. There should be a system in which these children are brought back at 6 weeks after an injection for an assessment to decide whether this child would benefit from further injections or not, and 12 to 26 weeks after, if necessary, to re-inject. And ideally, the injection and the pre-injection assessment and the post-injection assessment should be done by the same healthcare professional. It's very important in order to make that decision. So it is a multidisciplinary team, but always bearing in mind the International Classification of Function, Disability and Health, the ICF framework, because the impairment is there, but what's important is the activity and the participation. And your interventions should make a difference in both, not just the impairment, but the activity and the participation. And it's a whole lot of environmental factors and personal factors which factors into this, important. There are technical factors in terms of like how much to inject, the accuracy of injection technique, optimal doses, etc. The in terms of the addressing the in palliative reasons where you inject the hip flexors for addressing the pain. So all these are important. And sometimes, not sometimes, the orthopedic surgeons commonly use the toxin for post-operative spasms, and it can be very, very effective. Another important practical point is there are 2 or 3 major brands available, and these brands you can't just transfer one dose to the other, because the Dysport dosing and the Botox dosing are completely different. Again, very, very important to bear this in mind. And Xeomin also, it's completely different dosing. Equipments are very important. We need to make sure we have all this before we do it. I'll skip this for time's sake. How to reconstitute. It's very important to use ultrasound guided injections for toxin. So this is injecting the medial head of the gastrocs. So by using an ultrasound, you can guide exactly where you are injecting, and so there's no danger of like injecting too deep and going into the soleus, for example, and you can avoid any vascular or bleeding. There should be a like you should approach it like any other minor surgery in terms of the safety precautions, etc. So both time signing in, time out procedures should be followed, and there are established protocols and guidelines which you should be using. The gastrocs, soleus, the tip post, the hamstrings, the adductors, these are all like the common muscles that you would inject. Again, the physiotherapy and the follow-ups are important, post-injection therapy. So I'll quickly go through all that. That's the role for the physiotherapist. I think we're running out of time, aren't we? Perhaps we could just look at 1 or 2 cases. So yeah. So again, so this is our typical child with spastic diplegia, isn't it? But he presented at 9 months. And these are his range of movements, and as you can see that he's got dynamic catches in his hamstrings at 190, and he's got catches in his calf muscles as well, like quite early catches, -35 and minus 30 and -40, and nothing major, like other than a bit of my PVL, but nothing major. And so in terms of what treatment would be appropriate, you would think that he might be a candidate for selective dorsal rhizotomy, orthopedic surgery, ITB, botulinum toxin. So he had some oral medication and botulinum toxin, but the oral medications failed, and then he had botulinum toxin to his adductors, hamstrings and calves with good response. But then subsequently 2 further trials of treatment, he showed poor response. He had further multi-level injections, and then the hip x-rays were okay, and he underwent SDR at 6 years and 9 months, but he presented at 2, and then he was well maintained for several years with successfully with botulinum toxin. That So now the boy again with a left hemi, we can so he had angle foot orthosis and serial casting. So the main concerns were the tightness in the left ankle, frequent falls, and painful night spasms. So he would be an ideal candidate because, as you can see, his left ankle, 10-degree plantar flexion, there was a dynamic catch. So he had underwent botulinum toxin. With good results post toxin. So he went for multiple injections over several years, and in fact, this is him as an older child, and nearly perfect gait. So this is again a very successful case where, like, botulinum toxin injections over 4 or 5 years have done a major difference in terms of improving his gait. Perhaps I will show this one as well, and then we can stop. So a dystonic hemiplegia. So the thumb in palm, which was the main problem, so for her to hold onto the scale to get the thumb out, again, botulinum toxin injections to the biceps and the thumb would be very effective in this girl. So again, the muscle selection is very, very, very important. So I'll probably stop there, but in summary, toxin is a very effective intervention, but the choice of muscle is very important. But also what's important is your aims and goals that you do. The aims of intervention should always relate to function, activity, and participation, and not just removing, because sometimes some children need that little bit of spasticity for the helping with their ambulation and for helping with the daily living. So it's always like ascertain goals and then appropriate muscle selection and then inject, but inject only if you can make sure that there will be therapy afterwards. Without that, and without that commitment from the family, or without that commitment from your multidisciplinary team, you should not go into toxin injections. And even when you do, there should be an established system where you follow these children up properly and make a educated decision on whether to continue with injections or not. You should not get into the habit of like repeated injections after injection, because then that wouldn't be fair on the child or the family. I'll stop there. Thank you.
Thank you so much, sir, for that enlightening talk. I would first invite Dr. Tajul for any comments. Dr. Taj?
Hi.
Sir, your comments.
Yeah, Dr. Biju, fantastic talk as usual. And I loved all your videos. And I'm very fond of Botox injection for children with spasticity and dystonia. I'm also at awe of the fact that you were very at ease of using ultrasound guided, because the last 10 years I've been doing blind, and it's fantastic, and each time, a child with dystonia, because most of the times when you inject them Botox, we don't sedate them, and they're already very apprehensive. They're trying to move left, right, they're twisting here and then. I've always found that using an ultrasound is slightly a bit cumbersome, but in a few cases where I was not able to differentiate between, especially in a child with generalized dystonia and cervical dystonia, anticollis, torticollis with lateral collis, to differentiate between a dystonic, purely dystonic hypertrophic muscle versus a compensatory hypertrophic muscle, but a non-dystonic one. I've used a few patients' surface EMGs that were very helpful in certain cases, especially the cervical dystonias, but usually in those with spasticity, I'm so far comfortable with non-ultrasound guided, but yes, I think moving forward, if you have the facility and you have the patience to use ultrasound and inject the muscles, I think that'll be good. Yeah, thank you very much.
Thank you. Thanks, Raj.
Thank you, sir.
We are always advocating for use of ultrasound as a standard of care, because you could use EMG, but it's painful, isn't it? But you could argue that it's only one needle and you can inject it through it. But like as you mentioned, for retrocollis and lateral collis, like if you want to inject the splenius and if you want to particularly focus on upper fibers of the trapezius, etc., sometimes ultrasound is your handy tool. Point of care ultrasound is not limited to use by radiologists. Now, like
Exactly.
everybody uses it. If you go to an emergency department, they're all holding ultrasounds now. You don't have to.
Very true, very true.
Thank you, sir. Dr. Karan, please, your comments.
Firstly, thank you for your demonstrative cases and excellent presentation. Really, using the ultrasound, I think, increases the efficiency of botulinum injection. You just exactly direct the target. I would like to emphasize that as although the cerebral palsy is not a pure motor disorder, it also a systemic disorder. In that point, recently, botulinum toxin has been used in the treatment for drooling and dysphagia in cerebral palsy. Maybe a few years later, we can talk about more evidence about the efficacy of botulinum in drooling, as we accept cerebral palsy as a general systemic disorder. Thank you for your excellent presentation again.
As you were mentioning earlier, it's such a useful tool for addressing pain.
Yeah, of course, of course.
Thank you, sir. Dr. Farida, please, your comments.
Thank you, Dr. Biju. A very comprehensive, very well-rounded botulinum toxin today. It was really worth listening to all that. We do botulinum here, and as I would rightly say, agreeing to Dr. Taj, that I personally feel when the ultrasonologist is with me, I have this feeling that he or she is stealing my show. So, and of course, the area where I'm working, that also gets a bit limited with the next person right there with me. So we do it blindly. But if it's a difficult muscle and if I'm not sure, as you said, not to decide where I have to go, where I have to inject, then definitely I would go for one. And we do try to give mild sedation to the children so that anticipation that is there, that gets settled.
Yeah. More importantly, use of like we use midazolam because it takes away, it also causes gives some amnesia. So they go home and they forget about the whole thing. Yeah. So.
Yes. Thank you.
Thank you, ma'am. Mary, ma'am, your comments, please.
That was a fantastic talk. You covered everything. I'd like to ask you, what is the dose of botulinum toxin you use for children? What's the maximum dose, milligrams per kilogram?
So we use Dysport, and we use 30 units per kilo, but maximum of 1,000 units. So if it's a 40 kilo child, we would still only go for maximum 1,000 units, but 30 units per kilo. But again, it's also down to individual muscle. Like for example, in the biceps, you use 2 to 3 units per kilo, a total of like 75 to 150 units. But in the legs, you can use much higher doses. Like in the hamstrings, you can go from 5 units per kilo to 7.5 units per kilo. But like I said, like sometimes there's not much point in injecting too many muscles, and because you only have like 1,000 units to spread between the muscles, and you may want to inject too many muscles, but then you will end up injecting smaller under therapeutic doses in each muscle, and you won't get any effect. So it's very important to make that decision as to which muscles you feel like are the critical ones, and when you're injecting, you have to give a proper dose into those muscles. But if you speak to your orthopedic colleagues, they inject humongous doses into those muscles. And when we say like, oh, five units per kilo, they said like, oh, that's just homeopathic dose. They inject massive doses. But as neurologists, I think the reason why we go for this conservative doses is because we know that the side effects in terms of the antibodies and in terms of the diffusion is proportionate to the amount of toxin that we use. So you are handling a toxin, so you try and limit the amount that we are injecting into the child, particularly when we don't really know what is it going to do like 10 years, 20 years down the line. So we go follow strict guidelines on how many units per kilo to use. But in this sport, we never go for more than 30 units per kilo. That's the maximum. We never inject that high doses at all.
How can we choose between Dysport and Botox? What are the points that are for each of them?
Nothing. It's only for example, the Dysport comes in 500 unit vials, and it's just a case of like what your pharmacy wants to stock. Like for example, if it comes with smaller dose vials, then in children, like for example, you open a 500 unit vial and you only use 300 or 400, and if you don't have another child to inject the remaining 100, that's wasted. So those are the only practical reasons why you want to go for one other than the other. Obviously, you also have to look at the license. Like Xeomin, I think is probably not licensed for all interventions. So between Botox and Dysport, there is no problem. But if you start injecting with Dysport, then ideally you should continue with Dysport and not change to Botox, because one is on-botulinum toxin, the other is above-botulinum toxin. So there are slight differences between the two. But in terms of the use, like I said, it's mainly down to like reducing wastage. That's what it is, and the cost. Dysport was the cheaper option for us, hence we went for Dysport.
Changing between the two would be a good idea, because these antibodies will not form. I was just thinking, because both are different.
I don't know, but to be honest, I think this antibody has been sort of over-exaggerated. Antibody, if you speak to the Dysport people, and I've spoken to these manufacturers, they say that the antibody production is very rare. It is very rare. You don't really see that. Most of the time, when you don't see an effect, and we assume it is because of the child has developed antibodies, most of the time it is due to poor technique. Either the child didn't get enough toxin, or the way the toxin was stored, the toxin might not have been stored properly, and it lost its efficacy. The way it was reconstituted must have the bottle must have been shaken quite vigorously. So all those little things do matter, which is why I had that video, but because of time I couldn't show the way it was reconstituted. It is reconstituted very carefully, because if you start shaking it, and then the toxin will get affected and you won't get the efficacy, and you might wrongly think that it was because of antibodies we didn't get the effect. So it's a very sophisticated thing. You should not use it like willy-nilly like that. It's very important, we feel.
Thank you, Dr. Biju.
Okay.
Thank you, Dr. Biju, for a wonderful presentation. Wanted to ask you, and that's as usual for both of you, Taj and Biju, regarding drooling. Your Botox experience with drooling and the dosage.
I think it's a fantastic,
frequency.
fantastic tool, as Dr. Prasad was also saying, because what are the other options? You can go with glycopyrronium, hyoscine butyl bromide, and then you ask your friendly ENT colleague to do something, and they often do a ligation, which never works. It never works. Sometimes I don't know whether they even ligating the proper thing. The other option would be to remove it, to excise the glands. But there are issues with that as well. So toxin works very well, fantastically well and you can repeat it. It's pretty safe. And given that we are using drooling in children who most likely have impaired solo anyway, which also mitigates the potential side effect of the solo being affected. Most of these children are on gastrostomy anyway, and so I think we use a lot, and I think it's a very helpful tool, much more useful than ligation. Excision of salivary glands is a different thing, but ligation never works. And it's our feeling.
Thank
Dr.
you.
Taj?
Should we ask Vivek before Taj and Dr. Kusat? Vivek was there. Vivek, you want to bring that myoclonus in picture before Taj and Kusat, and then we'll request everybody to give the final take-home messages along with the queries. Yeah. Vivek?
Yeah, thanks. Thanks. Can you hear me now at last?
Yeah,
Yes.
all good and clear.
Yes.
Yeah.
Okay. So yeah, just coming straight to the point. So it's just an observation. Probably the audience here, which is so experienced, already knows about it. So and because it's an international audience, our causes of CP might be different from theirs. What we say is there is a two big groups, asphyxial brain injury and hypoglycemic brain injury. So the myoclonus is very interesting in these two groups, which I have observed over last few years, just collecting the patients. So the hypoglycemic babies, when they go home after 10, 12 days, after coming out of ICU, sugars are normal. From around 2 weeks to 4 months age, they have this erratic myoclonus in awake state, not in sleep, erratic myoclonus with normal sugars. And we've done multiple EEGs through those myoclonus and they are normal. So sort of 25 to 30% of hypoglycemic brain babies, not all of them. And when I was not sure what this was, I was giving them, pyridoxine, and I was thinking this is a metabolic disorder and doing genetic evaluation, even though the MRI was showing occipital damage, and that they all came to normal. So this is an interesting group. It just responds to clonazepam. And after 4 months, most of them develop infantile spasms, all those erratic myoclonus. So that's the hypoglycemic brain injury. Then there is this asphyxial brain injury patients who are fine till 4 to 5 months and then develop this reflex cortical myoclonus. You touch them and they have this jerking which look like clonic seizures. And they never develop spasms. And they just continue to have these reflex cortical myoclonus for 1 to 1.5 years. And they also respond to clonazepam. So this is something I just wanted to mention.
The observation on
I'm not great at basal ganglia circuitries, just observation. I don't know the reasons behind it. So it's just I wanted to share this, what I've been
But
seeing.
Dr. Vivek, I'll tell you what, all these myoclonus which comes in this asphyxia and this hypoglycemic babies in the initial part, yes, they have been responding to clonazepam. So when you were saying that you were getting all the investigations done and then started clonazepam, I was going to say you should have started to begin with. Yeah, but you were understanding your patients. Yeah, they do respond. But what Taj and was mentioning is in those dyskinetic CP which has formed later, which has come this is a post hypoglycemic brain injury thing what we are seeing. But we're talking about TCP, the dyskinetic CP. Yeah, in that when he's saying, then he's pointing out to actually, even I don't remember seeing myoclonus. I mean, that is what is there. But what you were saying in that situation, yes, we do see, and they do respond to clonazepam. Yes, I also agree with you in that situation. Yeah, Biju.
Yeah, I was saying it's a very interesting observation, particularly in relation to the development of spasms. The hypoglycemic injuries we don't tend to see a lot, and ideally we shouldn't be seeing any of those hypoglycemic injuries. But that's a very interesting observation. With the other one, the asphyxia, and those children who develop those later. Now, it would be interesting to see what Dr. Taj feels. Sometimes it can be very difficult to differentiate between cortical myoclonus and tremors, particularly when there is spasticity and hypertonia. Yeah. So, I don't know, like, tremors, myoclonus, it all depends on just the frequency, isn't it? What do you think, Dr. Taj?
So I think Vivek's observation is it's a very good observation, but probably to look at it in a context of a child with a brain injury in a more of an acute and subacute state versus in a child who has got brain injury with impairment of the nigrostriatal pathway and in a more chronic state when they've developed towards evolving towards DCP. Now, of course, I think I've coming from where Vivek has pointed out, there are a few cases where I've come across patients with hypoxic injury and in a subacute form, they have developed myoclonus and they tend to improve and respond to clonazepam, agreed, but they tend to disappear after some time. And the child tends to manifest more of a dyskinetic CP or a spastic CP form. So it's probably differentiating between acute subacute phase of injury and manifestation from the what you call cortical irritability or cortical damage versus more of a chronic phase where the nigrostriatal pathway is very much more affected and we are seeing the sequelae of it. Now, differentiating between myoclonus and tremor is usually pretty easy, except if it's a myoclonic tremor with a tremor per se, and then it's going to be difficult. When it is superimposed on a child with spastic cerebral palsy or spasticity, it's fantastically difficult. So usually, I think they tend to present with an answer with a serial review when a certain predominant movement tends to manifest in a more pronounced way. But if they tend to have tremor, in my clinical observation, majority of them tend to demonstrate some form of dystonia, especially the distal ones in later lives, within few months to a years. I've also seen in a lot of these patients with hypoxic ischemic encephalopathy, hypoxic injuries, they tend to present with tremors in a very initial states and later evolve to present as dystonic tremors. And one of the comments that I wanted to make on Dr. Biju's presentation was, I think you are right. The fear of antibody generation and non-response to one form of upper botulinum toxin versus the other one is probably slightly overrated, and we're still hanging on to it for the past 10 to 15 years. In my observation, and whenever I think of this, okay, this child is not responding to my injections, and I'm pretty sure I was injecting the same good group of muscle, the right group of muscles, and the doses that I've been using keeps on increasing. And usually in my very initial stage, I used to think that it's because of the antibodies, and I used to always wonder and wanted to change from Dysport to Botox because we don't have Xeomin at that point of time. But later I realized one of the major defining factor in non-responsiveness is the atrophy of the muscles themselves. You've injected them so many times, and I realized this after many years, because certain children, you inject them over years, 3 monthly to 6 monthly, I usually use about 30 units per kg in one session or 50 units in one side of the body. And later you realize after few years, the onset is usually within few years, not in the first 1 year, it's usually 2, 3, 4 years. You realize that your Botox is not working that well, or your injection is not working that well because the muscles have atrophied. I agree with you. I don't really think it's the antibody, but I'm not very sure, but I'm more convinced of the atrophy of the muscle rather than antibody.
That's a fantastic point, Dr. Tad, because even when we do the ultrasound, the muscles look different. And like I said, the orthopedic surgeons say that they can look at a muscle and say like whether this muscle has been injected with toxin or not. So it definitely causes some changes, long-term changes to the muscle. Current research is happening, but like we are seeing like few papers recently, but nothing major. So we even tried to see whether we could like take snapshots of the ultrasound and compare it with like each time. But it doesn't work out in a very busy clinic situation. But very important point. The atrophy is a real thing, but nobody knows about the long-term effects about toxin. Yeah.
Thank you to the fantastic duo. Now, I would request everyone to give their final comments, and I would be after you, Dr. Taj, and Dr. Kursat had a comment also to be made in addition to your final comment, and then Dr. Farida and Dr. Mary. Yeah, Dr. Bishu.
Oh, am I going first? All right. Okay.
No, Dr. Biju was going
All right.
first. Why is he
Okay.
not speaking?
That's
No,
right.
well, no. I think the important thing is managing cerebral palsy. Like if you know how to manage cerebral palsy, then you know 99% of pediatric neurology, and it should be multidisciplinary or even transdisciplinary. If I may say a couple more points, there was an interesting comment in the chat on why can't we just classify cerebral palsy based on the disability or something. I don't think that is a good idea. The reason is just like we have dystonia classification based on the phenotype, etc. It doesn't tell you anything about the function and the outcome. And the outcome is you can't compartmentalize outcome. So classify all CPs with swallow on one side, classify all CPs with hearing issues on one side. It's all interrelated. And for a transdisciplinary intervention, if a child is not speaking properly, it's not just the speech and language therapist who should work on it. It should be the occupational therapist, it should be the dietitian, it should be the speech and language therapist, it should be the behavior therapist. So it is transdisciplinary. So compartmentalizing children into one, seeing them as having one or the other disability, I don't think it would work. So in that point, my take-home message would be like goal setting is very important in a multidisciplinary care with the multi-team, and the focus should always be on activity and participation. And family fun, everything comes after that. Yeah.
So it should be realistic short-term goals. And Dr. Biju, I think Dr. Taj had answered all the questions in the chat. Can you just go through the questions in the chat? If anything is pending you want to answer, we'll come back to you in the end. So can you just go to the chat to the question answer to you? And sorry, I asked you to give a take home and then I realized I forgot your questions. Taj had already answered. Taj?
Yeah, so thank you, Dr. Professor Shefali. Probably my take-home message would be when you assess a child with cerebral palsy, think of dyskinetic cerebral palsy, because I think the numbers of dyskinetic cerebral palsies are going to increase. The percentage or the proportion of the prevalence of dyskinetic cerebral palsy is slowly going to increase as more and more of us are becoming more aware and familiarize ourselves with diagnosing dyskinesia in cerebral palsies. And also always keep a thinking hat, put on your thinking hat when you come across a child with dyskinetic cerebral palsy, look for red flag signs. And we don't want to just dump them in the wastebasket of cerebral palsy for years and years and years and miss out on a great opportunity of giving them a better, outcome, better functionability if we were able to find a diagnosis which probably has got more disease modifying medication or a specific treatment. Thank you.
Thank you. Yeah. Dr. Farida?
Thank you, Dr. Shefali. For me, taking each CP separately as an individual and tailoring the entire management according to the need of that particular CP would be the cornerstone of the management. If there are ophthalmic issues, I have to go there. If there are auditory issues, I have to go there. Diet. If a podiatrist is concerned, if I need physiotherapists, occupational, every CP has to be dealt according to the need to which that particular person needs to be catered for.
Absolutely. Holistic, multidisciplinary, actually transdisciplinary is the right term to be used here. Thank you so much. Dr. Kursat, you had to make a comment also earlier. You raised your hand and your take-home message.
Yeah. I fully agree with the previous speakers. Treatment must be multidisciplinary, but must be discussed with the family. All treatment options must be discussed with family. And after the discussion with the family, we can manage individually. both Botox, drugs, etc., etc. This is my home take message. Thank you.
Thank you, Dr. Mary.
Thank you, Dr. Shafai. I think the multidisciplinary treatment that we are giving is hospital-based. I hope in future we have a school-based multidisciplinary treatment, so they can be in their school and get their speech therapy, their behavior therapy, and all that in their own school environment. I hope that is available abroad. In India, it's all hospital-based. So they will not be able to attend school on many days because they have come together.
Very important point. Yeah. Absolutely.
And actually, some of them may not be able to come. So, in some situations, the CBR, the community-based, we have with family visits are also required in certain situations where they cannot. Dr. Biju, any questions you want to answer which have not been answered in the Q&A?
No, I think Q&A, I think any book or guidance for landmark guided injections without ultrasound. Oh, I don't know whether there are any book. If there are books on ultrasound, I can direct you to several books, and there are even apps available on ultrasound guided toxin. To an anonymous attendee. If they can contact me, I can even direct them to the right resources. I don't know about surface landmark guided injection book on landmark guided Botox injections. Dr. Taj, maybe I don't know. Maybe you are aware of thing, but I don't know. But there are also comments on ultrasound is very useful. I agree with that. Rule of thumb of a Botox dose. I don't think there's any rule of thumb. There are, as a unit, your facility should decide on the injections. The company, Botox manufacturers will give you guidelines on how much how much units to use. Maximum number of Botox injections which can be given, there is no maximum number as such. It all depends on the number of muscle selections. There is no absolute number that you have to limit with you. Is post-Botox casting necessary or beneficial? Absolutely, yes. For how long we should wait to give toxin after the aminoglycoside course? I think you should not use toxin when the child is on antibiotics. After that, it's fine. I don't think there's any problem. How can you practically overcome the fear of parents for losing the newly learned function in the presence of spasticity by reducing the tone? That's a good question, because some children use the spasticity to, particularly the spastic dystonic children. Some children use the spasticity to mask the dystonia. You remove the spasticity and the dystonia gets worse, and the parents feel that like the child's function is gone. It's important, as Dr. Kusar said, to have the family on board in the journey, as Dr. Taj mentioned, the journey for CP, with the family and child in the center, and all these professionals working around the child. If we have the family on board, then they will work with you, I think. Thank you.
There is one or two more above that.
Botulinum toxin. Botulinum toxin be useful in gaining selective motor control. Selective motor control in spastic CP. Can botulinum toxin be useful? Absolutely, yes. And that is a major goal in helping improving selective motor control. Absolutely. What is the reason behind that some CP patients go into refractory seizures, West syndrome? Is that due to genetic reasons or due to the affected area? In another word, is it acceptable for CP patients to have refractory seizures? Using ketogenic diet in this group? No, I mean, there are obvious reasons that we already do, isn't it? Like hypoglycemic injury, high incidence, hypoxic ischemic injury, high incidence. But CP per se and infantile spasms or refractory West syndrome, I don't think so. Unless the same etiology, the common etiology which is caused by the CP and the seizures. But there are obvious reasons that we know, like the hypoglycemic injuries and the hypoxic ischemic injuries are notorious causes, aren't they? Yeah.
Thank you so much. And I think we will be really grateful to all of the speakers and the experts. We will be having the next session after 2 weeks, and that will be on traumatic brain injury. Palsy Torres being there, and Dr. Bijum. And we welcome you all. I will be sending out notices soon for the 70th AOCCN to be held in Yashabhumi next year. So just watch out for the next notices. Thank you. And Mahesh, anything in the end? And sorry, Ekta, I forgot you. Ekta, thank you so much for moderating well. Anything you would like to say or ask?
No, ma'am, no, ma'am. Thank you so much. It was a great
Thank you.
honor
Thank
to moderate the
Thank-
session.
Thank you. Thank you. And Mahesh?
Nothing, ma'am. It was a really nice discussion, ma'am. So I'll be putting the details of the next webinar in the WhatsApp group.
Yeah, and we'll just put on for the AOCCN also. AOCCN also in the thing. Yeah, thank you. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Good night. Good night.
Thank
Bye.
you.
Bye.
Bye.
Bye-bye.
Good night.
Bye-bye.
Bye-bye. Good night.
Nice. Nice.